So good morning, everyone, and you're very welcome to our meeting. I'm Henry O'Connell, consultant psychiatrist in Portlaoise and adjunct associate clinical professor in the School of Medicine in University of Limerick. This is the third meeting of our Evolution and Psychiatry Special Interest Group. Our first meeting was in Darwin Day, February 12th of this year, when we had Mike Watts giving us an excellent overview on evolutionary science. In May, we had our colleague Ria Debed from the UK talking about the evolutionary psychiatry of eating disorders. And today, we're really delighted to be able to welcome our colleague from the UK, Dr Annie Swanepoel, who is a consultant in child psychiatry. Annie is going to talk to us about ADHD and maybe some aspects of ASD as well. After Annie's talk, we will have a brief business meeting. Annie's talk will probably run until 10:45 or so, and we'll have questions and answers at the end. Then we'll have a brief business meeting and draw things to a close, probably by around 11:30. So I'm going to just formally welcome and introduce Annie, our speaker for this morning. Annie is a consultant child and adolescent psychiatrist who works in a team for children with severe learning disability in Essex. Annie previously worked in general outpatient CAMS and also in a low secure inpatient unit. Annie holds a PhD in human physiology, and her special interests include neurodevelopmental disorders, developmental trauma, and evolutionary psychiatry. And Annie is also the editor of the Evolutionary Psychiatry Special Interest Group newsletter with the Royal College, and she is a very active member of that special interest group. So thank you, Annie, you're very welcome, and I'll let you take it from there.
Thank you very much for that kind introduction. I'm going to see, okay, you can see my slides?
Yes.
Okay. So I want to talk about evolutionary perspectives on autism and ADHD. And I'm going to talk about why I think an evolutionary perspective is helpful, then say a few words about autism, ADHD, neurodevelopmental trauma, and then pull it all together. So the reason why I think an evolutionary perspective is helpful is because it helps us understand why children have particular problems. I find in the rest of psychiatry, often we only try to understand what happens and how does it happen, but rarely do people ask why. And an evolutionary view helps us to see which behaviors are pathological and which are adaptive strategies. And I like this quote from Dobzhansky, which says, "Nothing in biology makes sense except in the light of evolution." Charles Darwin, in The Origin of the Species, wrote the following, which I think is worth reading out in full. "As many more individuals of each species are born than can survive, and as, consequently, there is a frequent struggle for existence, it follows that any being, if it vary, however slightly, in any manner profitable to itself, under the complex and sometimes varying conditions of life, will have a better chance of surviving and thus be naturally selected. So from the strong principle of inheritance, any selected variety will tend to propagate its new and modified form. And that is the basis of evolution. And a key insight for me, because you know how when people hear about evolution, they know about survival of the fittest. And what it actually refers to is that it's survival of those individuals that fit best in their environment, so those that are best adapted to their environment. So it's not really about strength or intelligence, but about the goodness of fit between the individual and their environment. That is key. Tinbergen is famous for posing these 4 questions and saying that that is what we need to look at if we want to understand any behavior. So that includes something like ADHD and autism. So how does it work? What's the mechanism? And that we have lots of information on. So that's neurotransmitters and brain anatomy. How did it develop? That is something which there's less information on, but the psychiatry does research on that. But then the question, how is this behavior adaptive? What is the survival value of this behavior is something which I didn't come across at all until I learned about evolution and psychiatry. It's just not something that psychiatrists typically think about. And I think it's a very important question because it helps us understand that not everything is pathological. And how has it evolved? So looking at other species. And evolutionary science is holistic. So you know that genes are responsible for lots of different things, and we know that. We know that there's a biological predisposition. But what evolution shows us is that why are these genes there in the first place? So why did these genes persist? What were the environmental influences over evolutionary history? And then the other thing, of course, is that during an individual's lifetime, there are gene-environment interactions with epigenetics. So clearly, genes that influence the brain cannot be considered separate from the body and the environment. So if we look at autism spectrum disorder first, we know that autism spectrum disorder is there's a whole variety from the very low functioning intellectual disability autism up to high functioning autism. And what we are saying is that autism is a disorder rather than an adaptation for those who have single mutation genetic changes and genetic syndromes. So these individuals often have significant intellectual disabilities. So we're not arguing that this is adaptive or it is clearly a disorder, and about 3 to 10 cases of autism are related to rare genetic variants. And same goes, of course, for teratogens, so valproate, alcohol, and other disorders which cause damage, which then causes the disorder with autistic traits. So when autism is accompanied by intellectual disability, this cannot be classed as evolved or adaptive. But high-functioning autism is adaptive. We know that high-functioning autism is highly heritable, but it's due to multiple genes that each have a small effect. And we also know that alleles for autism overlap broadly with alleles for high intelligence. Now, why would these genes persist? Because we know that across traditional societies, mothers have to adjust the amount of investment they put into their children based on their on social and ecological circumstances. So infants who are very skilled at getting their mother's attention by making eye contact, by babbling, by learning what mum wants and what she likes, have a much higher chance of surviving. So that would mean that children with autism who don't make eye contact, who are less likely to communicate by babbling, would be at a disadvantage to mothers who did not have adequate social support. But with autism, we know that it occurs more commonly with increased paternal age. And this may be adaptive in the sense that the child with autism, who tends to develop more slowly and need more support initially, is born into a family in which the father is more established and where there are older siblings to help. And this brings us to slow life history. So if you think about elephants, they have very few offspring and they put a lot of time into rearing them, compared to, for example, rabbits, which we'll talk about a bit later in the fast life history. So slow life history individuals defer reproduction, tend to have fewer offspring, in whom they invest a lot, with a focus on quality rather than quantity. And individuals with high-functioning autism typically follow a slow life history, with muted sex drive, but with preserved or heightened interest in romantic relationships, increased investment of time and resources in long-term partners and children. And there are pros and cons of a social style in autism, because People who don't spend much time on mentalizing means that people with high functioning autism tend to have straightforward social styles because they don't alter their behaviors and opinions to make a good impression on others. Interestingly, that is then recognized as being trustworthy, and such people are often seen as reliable cooperation partners despite their relative lack of social agreeableness. We also think that in hunter-gatherers, autism is sufficiently common that in the groups of 100 to 150 individuals in which hunter-gatherers usually convene, there would have been one or two autistic individuals. And high-functioning people with autism often have outstanding abilities in memory and spatial skills and develop expertise in their special interest. And this may have been very important in making tools and weapons, and in such a way autism may have benefited the whole group if you had an individual who could persist in making arrow points, for example, in order to really get it down to a T. So just to summarize what I've said about autism, if it's associated with intellectual disability, it's a disorder. We're not saying it's adaptive. But high-functioning autism can be adaptive. These people are more likely to follow a slow life history. Advanced paternal age and presence of older siblings can make up for lack in social skills of a youngster with autism. And systemizing and special interests of people with autism can be beneficial for the tribe. And that, of course, is still the case nowadays in our life, where people with high-functioning autism do extremely well in computer science, maths, physics, and also anything which grabs their special interest. So if we now go over to ADHD, again, according to evolutionary thinking, behavior traits that have survived and been passed down the generations must have had adaptive value in the past and possibly still have today. And one example of this may be that a seventh of the Ariol tribe in Kenya have the long version of the dopamine D4 receptor gene, the DRD4 gene. And the long version of this gene is associated with novelty seeking. So this was an advantage when living in a nomadic life, but not when settled. So we can speculate that people who had this gene, which was novelty seeking, would be more inclined to seek greener pastures when danger loomed, and be more inclined to survive and pass on this variant. We know that ADHD is more common in males, and that is also understandable from an evolutionary point of view because males have to be more risk-taking to compete for mates, since a higher proportion of males than females fail to have children and pass on their genes. So evidence suggests that human-male competition over evolutionary history has frequently taken the form of physical contests with rival males, and their hyperactivity, impulsivity might have been an advantage. Nowadays, of course, that's not the case anymore, because even 100 years ago, most boys would have learned a trade from their father, which means that they would have biologically likely been similar to their fathers and therefore learned a trade which suited them, which their father managed in. But this all changed with schooling. And nowadays, schools can be seen as feminized institutions because the large majority of teachers are women. And schools favor the more acquiescent behaviors that are typically found in girls, which leads to a real disadvantage to boisterous boys. This brings us to the concept of an evolutionary mismatch. So that occurs when the environment in which an organism lives now is significantly different from that in which it evolved, so that traits that were once adaptive may then become pathological. And the example, which is very easy to understand, is in our evolutionary history, we had to cope with little food. So it was always difficult to get enough food, and very rarely was there a surplus of food. So those of us who survived were the ones who were really good at eating when there was food around and storing it in fat when this was possible, in order to then survive the next famine. Nowadays, that's not a problem anymore. Now, there's lots of cheap, plentiful, high-calorie food available. And with our evolutionary history being adapted to eat when we've got food around, leads to a widespread obesity epidemic. And that is due to an evolutionary mismatch. Now we can say that ADHD is an evolutionary mismatch too, because there's no way in which children in evolutionary times were expected to sit still in a classroom for 5 to 6 hours per day, 200 days per year. It's just nothing that evolution prepared children to be able to cope with. So there's a real mismatch between the strengths of children with ADHD, their tendency to explore, they have more of the DRD4 gene as well, to challenge, to try out new ways of doing things, and today's schools where you're expected to sit still, pay attention, and listen. And children with ADHD may have an enhanced performance if they're allowed to learn while moving around. And we know that people with ADHD can outperform others in stressful, changing conditions that require intense physical activity. So, for example, in the military, people with ADHD can do extremely well because they can switch very easily between tasks. They don't mind being physically active for long amounts of time. So it's in the right situation, ADHD is a strength and an adaptation. Now, treating children with ADHD is tricky because many people argue that normal children are being medicated to make them less naughty, and this is a form of social control. But we know that medication may help to ensure better educational outcomes and less involvement in drugs and youth offending. So, in practice, it doesn't really matter whether ADHD is genetic or behavioral or neurodevelopmental, because it's all about the goodness of fit. So evolutionary thinking helps us to see that the key question is, should a psychiatrist prescribe medication to help a child fit into an environment that is not ideal? So I come back to what I said initially about survival of the fittest, meaning the best fit, the goodness of fit. If a child with ADHD who wants to run around, be active, do lots of different things, explore, doesn't fit into our standard schools where children are expected to sit down and pay attention, should we be changing the environment, or should we be prescribing medication to change the child? And that is a real ethical problem, because often we don't have the resources to change, or as psychiatrists, the authority to change the school environment. And there's often a clear conflict of interest between what is best for the child and what is easiest for parents and teachers. And that can be particularly difficult then for children who don't necessarily want to take medication, but whose parents want them to take medication. So understanding ADHD as a biological variant that can have adaptive value may help to shift perceptions of children from being naughty or abnormal to being seen as caught in an evolutionary mismatch. So behavioral strategies in school could, for example, focus on allowing plenty of physical activity for children with ADHD. And I really think that schools need to be redesigned for children with ADHD. And with the Equality Act, they have a legal right to reasonable adjustments, but that isn't happening. The children are expected to comply. The schools aren't making reasonable adjustments, in my view, for children with ADHD. And then when talking about neurodevelopmental disorders, I think I can't do the talk without considering neurodevelopmental trauma. We know that adverse childhood experiences are rooted in adverse community environments. So in situations where families experience poverty, discrimination, poor housing, domestic violence, homelessness, that can very, very easily lead to an impact on the children as well, through physical and emotional neglect, um, emotional sexual abuse, depression or mental illness in parents. And I'm in no way saying it only happens in these situations, but it's much more common when parents are very stressed. And that is where fast life history can be adaptive. So remember I spoke about elephants as a slow life history? Now, fast life history individuals begin reproducing at a young age, tend to have more offspring, each of whom gets relatively little nurturance. So there's a focus on quantity rather than quality. And this is more adaptive in harsh and dangerous environments where many young are expected to die. Because if you only have one young one, like elephants would do, and something happens to that young one and it dies, you haven't propagated your genes. Now, I'm not saying this is a conscious process, not at all, and that is where the genius of Darwin was in describing in the origin of the species with a quote I read out earlier. And Darwin was really struck and upset by seeing how nature dealt with it, that there's really an overproduction of young with only some of them surviving, and those who were best adapted to their situation surviving and the others dying. So it's not in any way ideal or benign, but it is adaptive in a harsh and dangerous environment. So we know that there's intrauterine programming happening, so that dangerous environments would lead to a fearful mother who's less able to provide sensitive and warm care. This calibrates the infant's HPA axis, making them more reactive to fear, more hypervigilant, and therefore prepares the infant for the postnatal environment it's likely to encounter, so dangerous environment. So the intrauterine programming, which we have previously seen only as pathological, so that children are born with being very stress reactive, is adaptive for a dangerous environment, even if it causes considerable suffering, because it's not, evolution doesn't select for happiness, it selects for survival. And this is just a slide to show that when there's threat and stress, it affects the whole body. So it's not just the brain, it affects all the endocrine systems, the immune system. So you don't only get mental health problems, you get physical health problems as well from being in a dangerous environment or from having a mother who in pregnancy was in a dangerous environment. And that's where we then get this cycle and the intergenerational transmission of trauma. So where adverse childhood experiences lead to disrupted neurodevelopment, which lead to the adoption of health risk behaviors, disease and social problems, then you get, when these people have children, you get the cycle continuing again, and early death. But this won't be stopped through natural selection because reproduction happens. And that is where life history theory is important, where fast life history explains how less trust and more risk-taking may be adaptive for abusive homes or violent neighborhoods. And it ensures short-term survival, though at a cost to long-term physical and mental health. And ADHD, people with ADHD often follow more of a fast life history because they are impulsive and they can often reproduce much earlier and not live for as long. Now, in terms of diagnosis, as a child and adolescent psychiatrist, we need to think, because we often see children who come to us who have difficulty in focusing and concentrating, who have problems with executive functions, really struggling at school, can't regulate their emotions, and can therefore be misdiagnosed as having ADHD because they can't concentrate, they can't relax. And actually what we're seeing then is post-traumatic stress disorder. We're seeing a child who's hypervigilant, who might be having flashbacks. But that doesn't mean there's not ADHD, but I'll come to that. Similarly, we can get this quasi-autism. So we've seen that children who were neglected, in particularly the ones from Romanian orphanages, they showed very typical symptoms like rocking, an inability to manage change, very limited verbal ability, little desire to be close to others or seek comfort or to understand others or their own emotions. So had a very autistic picture, but it isn't autism because these symptoms often improved when children were adopted into caring families, particularly if it happened at a young enough age. So I just want to make it very clear that I've come across it so many times where people say, is it ADHD or is it abuse? Is it autism or is it neglect? And we need to be aware and recognize that children with ADHD and ASD are more likely to also suffer maltreatment. And there's been lots of studies about that because these children are more difficult to care for. They are more likely to be abused or neglected. So the presence of maltreatment does not prove the absence of a neurodevelopmental disorder. And the presence of a neurodevelopmental disorder does not prove the absence of maltreatment. And I actually think that in many, many cases, both are there. So both the maltreatment and neurodevelopmental disorder, particularly the very complex cases we see as child psychiatrists. So just to pull things to a close, for people with ASD and or ADHD, an evolutionary perspective might help them to understand their strengths and to seek occupations where these are valued. So again, thinking about the goodness of fit, finding an environment in which your special interests or your ability to cope with little sleep and doing lots of physical exercise is a plus point, can really help and can help these people outperform neurotypical individuals. Reframing these conditions in evolutionary terms paves the way for a more informed discussion of the complexities of the disorder, or I don't think they should be called disorders really, adaptations or variations, and of our ethical and social responsibilities towards people in these groups, particularly schools. So there needs to be more of a focus on neurodiversity rather than pathology. And that is what I like about the evolutionary view. People aren't all the same, and that's a good thing because the world isn't all the same. So you need people with different strengths, different skills to be able to fit into different aspects of our lives. So understanding the evolutionary mechanisms behind our unique universal human vulnerabilities enables a depth of understanding and empathy that will enhance the insights of future generations of psychiatrists. And that I think is important because it's not just thinking about pathology, it's thinking about variability, adaptation, and strengths. And this will increase future psychiatrists' effectiveness providing new research strategies and reducing stigma, shame, and blame for patients. And this talk is based on a chapter that my colleagues and I have written for a textbook of evolutionary psychiatry, which is due to be published in 2022 by the Royal College of Psychiatrists and Cambridge University Press. Thank you for listening.
Okay, thank you, Annie. Can you hear me?
Yes.
Yeah, can. Thank you so much. That was a really excellent overview. I really enjoyed that. You managed to introduce us again to so many fundamental principles of evolutionary thinking, and also covered a wide range of very serious psychiatric disorders. And I have a lot of questions, but I might just start with one or two and then open it up to the rest of the audience. I'm particularly interested in clinical practical applications of evolutionary thinking in clinical practice. And in relation to ADHD, the way you described it, there's huge potential there in terms of interacting with the school system, informing educational practices, and so on. So I'm just wondering, bearing in mind the evolutionary perspective, how does that inform your practice for individual children presenting with what may seem like ADHD, and what advice would you have for, say, schools and school principals in terms of modifying the environment and improving it for kids?
Oh, Henry, this is something I have thought about a lot. So I have had children. If I can put it this way, the evolutionary view in terms of ADHD has really helped me a great deal, because I used to think before that I should treat children if it's biological ADHD. I should prescribe medication, and I shouldn't prescribe medication if it has to do with environmental stuff. And what the evolutionary view has shown me is it doesn't matter. What I need to consider is the goodness of fit. So, my first priority when I have a child with ADHD symptoms is to try and change the environment. So to say to parents, take this child out, this child needs lots and lots of exercise. Sorry, I hear an echo. Can people please be on mute if they're not talking? Thank you. So my first priority is to try and change the environment. So for example, if the child is struggling at home, to say to parents, if you're able to get a trampoline, take the child out to the park. And at schools, I remember once having a child who so the mother brought the child to my clinic, said this child had ADHD. The child was all over in the room, clearly had ADHD, but the school report said no, the child didn't have ADHD. So I was absolutely fascinated by that. Went to see the child in school. The child had clear symptoms of ADHD, but the teacher was just brilliant at managing it. And what she'd do is, when she saw the child couldn't sit still anymore, she would ask him to take a big pile of books to a teacher on the other side of the school. And then he would be carrying this big pile of books to the other side of the school, run back, and then he could sit still again. And she had an arrangement with a teacher on the other side of the school who also had a child like that they'd be sending the same pile of books to and fro whenever the child in their class couldn't sit still anymore. And at that point, I said to the mother, we're not treating this child because he doesn't need it. He's coping fine at school. But then a year later, he had a different teacher who didn't manage it in the same way. And then he started on medication. And I've also had a child, a bigger boy, who I treated on medication, and he managed to get his GCSEs. And then the next follow-up appointment, he told me he'd stopped his medication. And I said, oh, that is not a good idea. You know, when you're in post-16 education, you really need to be able to concentrate. And he said to me, no, but I can concentrate fine. And I said, what? He was in football college. So they did 2 hours of football, 1 hour of maths, 2 hours of football, 1 hour of English. And he could concentrate fine after having run around for 2 hours. So I really think that perhaps there should be schools for children with ADHD. But I used to think so, actually, and then I thought no, because I think neurotypical children also aren't getting enough exercise. And it would be a really good thing for all children to be able to run around and get more physical exercise in schools. So I think there's a real gap, because I know teachers are scared of spending that time on that, but I think they would get that time back in increased concentration that the children would be able to give.
Thank you, Annie. Yes.
You're on mute.
Okay, thank you, Annie. That was really fascinating, and I must say I agree with your perspectives on this. And I'm conscious as well, we may have attendees from the ADHD special interest group. So I just want to open it up to people. Does anyone have any comments or questions in relation to the ADHD aspects of Annie's talk? No. No, okay. And I'm curious as well, Annie, do you ever prescribe stimulants then? Or do you see a role for stimulant medication in some kids?
Absolutely, yes. So it can make such a difference for children. So I'm not against medication. I think medication can be life-saving for children and certainly school career saving for children. But I think I think as psychiatrists, we put in the situation, not just for ADHD, but for many things, where we are asked to prescribe medication for a situation which really is quite awful, and where lots more is needed, not just medication. And I think that if we just think about the disorder as a pathology, we think, okay, we need to prescribe medication without considering the broader aspect. And that's where I like the evolutionary view, the goodness of fit view, that it's not pathological, it's a variation. So what we need to do is to consider the environment as well. And that is true for ADHD and for autism, but is also true for depression and for anxiety. So it's the biopsychosocial view, really, which evolution brings out so nicely.
Okay.
Henry, I can see somebody has their
Okay.
hand.
Yeah, Margo. You'll have to unmute Margo.
Yeah,
great.
Am I go ahead? Thank you, Annie, for your talk, which I found absolutely fascinating. I'm involved with the Adult ADHD National Clinical Programme here in Ireland, and I loved your vignette about how a teacher could deal very well with a child. I wonder, and this may be maybe a bit unfair because I'm talking about adults, but there is certainly in this country anyway, a huge pressure for people to go into third level education. Unless you go to university, you haven't really succeeded. And given what you're talking about, the strengths of people with ADHD and the sort of jobs that they might flourish in, a lot of them do find it very difficult, if not impossible, to manage in college. And I wondered, had you any thoughts about how we might intervene, either in terms of the setting where they're trying to get their education at third level, and also whether there might be some way of reframing what are good career options for people with ADHD.
Yeah, well, I think people with ADHD can go to college and can go to university and do all those things because we have medication which can help them concentrate. So I wouldn't say that those options are not available to them, but I would want them to think about things which people have always seen as weaknesses. For example, their inability to sleep 8 hours per night, or their constantly wanting to fidget and wanting to move, and to reframe those as strengths. Because there are lots of jobs where if you don't, if you're not so dependent on having a regular block of sleep, you could do extremely well. Medicine being one of them. I don't know about the rest of you, but certainly I've found it hard wanting my sleep. So yes, I think it's more about reframing it as neurodiversity and looking at the what's typically been framed as weaknesses and seeing where those could be strengths.
Okay, thank you. That's very helpful.
Okay. Thank you, Annie. And
I see Mara wrote in the chat. So she said, outside schools reportedly work well for ADHD children, but not a solution overall. Yeah. How do we diagnose ADHD efficiently and objectively? From my experience, there are various different questionnaires that vary, no global standard yet. Yes, so it's the, that's why it's about a specialist assessment. And I think it's about understanding complexity. So seeing ADHD not as a simple thing, sometimes it is, but often it's not. And understanding complexity, understanding that maltreatment doesn't rule out ADHD, and just seeing the whole
Annie, apologies, you're on mute. I went to mute someone else. Apologies.
Anything. Can you hear me now?
Yeah.
So what medication would you recommend for ASD-associated mental disorders? I assume this is in the context of ADHD or not. Well, let me put it this way. So with autism, what I found is they are very, very sensitive to SSRIs. So I use very small doses for people with autism. So sertraline, 25 milligrams maximum. And that can make a real difference in terms of just taking the edge off the social anxiety. Whereas if you give a higher dose, they get terrible side effects and then it doesn't work for them. I'll leave it there. I don't have any particular thoughts about the big population we see who have autism and ADHD. So for them, I follow the normal guidelines. I currently work in a team with children with intellectual disability. And for them, I've definitely found that stimulants don't work, make things worse. And for them, I've found guanfacine or clonidine particularly helpful. Also, guanfacine and clonidine are very good for children with ADHD who also have PTSD because it reduces the arousal, and it's actually listed in the Maudsley guidelines under possible treatment for PTSD. So if you've got these cases where it's ADHD and trauma, consider something like guanfacine or clonidine.
Could I just move on and ask you just a question about the ASD part of your talk? Again, I'm just conscious of the research by Bernard Crespi in relation to this notion of a diametric hypothesis, where many of the alleles and the traits associated with ASD may be mirror images and the opposite to what we see in psychotic and affective disorders. Okay, so for example, areas such as theory of mind that are maybe impaired in ASD spectrum disorders may be heightened in psychotic and affective disorders. And I think it's a very interesting area in terms of the basic science research. And in terms of clinical implications, it seems to be that one of the outputs is that psychotherapy in people with ASD may benefit from having a focus on people, on making people more, if you can, to put it bluntly, to be more psychotic and affective. So it's about developing theory of mind, empathy skills, social cognition and so on. And maybe there may be a therapeutic implication for people with psychotic and affective disorders to make them, in a sense, more autistic. So to bring people into a more balanced center point between ASD at one extreme and psychotic affective at the other. So I'm just wondering, with that kind of background in mind, and I think psychotherapy is a really important focus for evolutionary perspectives. How do you think the evolutionary perspective influences your approach to psychotherapy in people with ASD, and maybe in supporting their families, especially people who have comorbid intellectual disabilities as well?
Well, the evolutionary view, I think, is captured very well by nidotherapy. So nidotherapy is around those people who've been found to be resistant to traditional ways of helping them, medication and psychotherapy. So often people with entrenched personality disorders. And nidotherapy is then around creating their environment. So rather than trying to work on the individual, you work on the environment. So finding people who can befriend them, or getting them to do community activities, just practical things like improving housing. And in working with children with severe intellectual disabilities, that's my focus. So I don't, or very rarely, work with a child directly, but it's all around helping others to understand the child, helping others to adjust the way they respond to the child, the school and the home, in order to adapt the environment so that the child fits better into the environment. So that there is where I think an evolutionary view is helpful. I found really, and I know I've said this more than once now, but for me this is such a key concept, that it's around the goodness of fit. So you don't have to think about just the pathology in the individual. It's around, when you've got the individual the way they are, how can you help them adapt better? And that's by either changing the individual through therapy or medication, or changing the environment. And sometimes or very often it's both. And I think as psychiatrists, we can get stuck into thinking pathology, medication, and forget about the other things we could do to make our patients' lives better.
Thank you. And again, just to open it up, does anyone have any other questions or comments? Just a final reflection then as well, Annie. The idea of fast and slow life history strategy, I think it's very interesting as well. It comes from the evolutionary perspective, and I think it can be very helpful in informing how we perceive and react to people with, especially with fast life history strategies. People who seem to be making unwise decisions, who are noisy in their interactions with our services, who seem to create havoc wherever they go. But that notion of fast life history, and the fact that people in those situations oftentimes are traumatized, that their early adaptive responses were appropriate to their environment in a kind of a fight or flight sense. But unfortunately, they perpetuate that pattern of behavior then for the rest of their lives, causing them undue harm. So again, it may have implications in terms of psychotherapy, in terms of giving people explanations as to how and why they behave in certain ways over the whole course of their lifetime, in ways that are potentially destructive at different stages. But maybe the origins of these behaviors comes from trauma, and the fact that adopting that fast life history fight or flight strategy was actually a survival strategy in the early days for the person.
Yes, I remember when I worked in the inpatient unit, one of my patients on her 17th birthday was absolutely distraught. She was crying and crying and crying. And when I asked her what the matter was, she said she reached 17 without having a baby. So she was born when her mother was 16. Her mother was born when the mother's mother was 16, and she felt she was useless for not having a baby by the time she was 17. And for her, it was very interesting to then hear about the ages the staff members were when they had babies, their first babies. And she was absolutely amazed to think that people could wait until they were 30 to have a baby, because in her view, you were a grandmother by the time you were 32. So yes, absolutely. I think the way we see people live, the way our ancestors have lived, for us this is how the world works. And sometimes just having it explained as there's actually a spectrum. Some people have a very fast life history, others have a very slow life history, and there's different ways of doing things, can open up possibilities to do things differently. So yes, I did find it useful to have that conversation with her, and to say it's a good thing that she didn't have a baby yet, and it gives her much more chances, because she was the only one who actually had any GCSEs. So yes, just explaining it to her as moving towards a different life strategy rather than a failure.
Yes. Okay, so does anyone have any other questions for Annie while she's still with us? No? Okay, so I'll just draw this part of the meeting to a close then, and thank Helen for organising all of this, and especially thank Annie for giving us such a really comprehensive and clear overview, and some very good clinical perspectives as well on how the evolutionary perspective can be helpful for our patients. So
thank you very much.